Antibiotic Stewardship and Escalation, a critical conversation in modern medicine exploring appropriate use and timely escalation of antibiotic therapy. Hello and welcome to today's episode, where we delve into one of the most critical topics in contemporary healthcare, antibiotic stewardship and the indications for escalating antibiotic therapy. This discussion is essential for clinicians, pharmacists, students, and anyone interested in the ongoing battle against antimicrobial resistance. Antibiotic stewardship, definition and purpose. To begin, let us clarify what we mean by antibiotic stewardship. Antibiotic stewardship is a coordinated, systematic effort that aims to promote the appropriate use of antimicrobial medicines. The focus is not on restricting access to these drugs, but rather on optimizing patient outcomes, ensuring cost-effective treatment, and minimizing the unintended consequences of antibiotic use, particularly the development of antimicrobial resistance. In stewardship programs, you may hear the guiding mantra, the right drug, for the right organism, at the right dose, for the right duration. This principle underpins everything we do in clinical practice to ensure antibiotics are used judiciously. Core principles and goals of stewardship. The goals of antibiotic stewardship are fourfold. First, it seeks to improve patient outcomes by ensuring patients receive effective therapy for their infections, resulting in quicker recoveries and reduced mortality rates. Second, stewardship aims to minimize toxicity and adverse events, such as infections caused by Clostridium difficile, organ toxicity, and allergic reactions. Third, it is crucial in reducing the emergence of resistance, as inappropriate antibiotic use remains the leading driver of antimicrobial resistance, a global health crisis. Lastly, stewardship promotes cost-effectiveness by avoiding unnecessary medications, shortening hospital stays, and preventing complications. Key strategies and interventions. Stewardship programs typically revolve around two primary actions. The first is a prospective review, where a stewardship expert, often an infectious diseases pharmacist or physician, examines antibiotic prescriptions and provides tailored recommendations after the drug has been initiated. The second action involves formulary restrictions or pre-authorization, which means certain high-risk or broad-spectrum antibiotics require approval from the stewardship team before they can be prescribed. Other essential strategies include developing guidelines and pathways specific to institutions for common infections, such as pneumonia, urinary tract infections, and skin infections. A critical feature is the antibiotic timeout, a mandatory reassessment of the antibiotic regimen at 48 to 72 hours. At this stage, initial culture results are usually available, and the patient's clinical progress is clearer. The healthcare team must then ask, does the patient have an infection that will respond to antibiotics? Can we narrow the spectrum of therapy? Is the current route optimal? Could we switch from intravenous to oral administration? And, is the duration appropriate? Switching from intravenous to oral antibiotics as soon as it is clinically feasible offers multiple benefits. It improves patient comfort, lowers the risk of line-associated infections, and can facilitate earlier discharge from hospital. Dose optimization is another key strategy, using pharmacokinetic and pharmacodynamic principles to ensure doses are sufficient to eradicate the infection, particularly in critically ill patients or those with resistant organisms. Indications for escalating antibiotic therapy. Now, let us turn to the topic of escalation. Escalation of therapy refers to broadening or changing the antibiotic regimen to one with a wider spectrum of activity or a different mechanism of action. This is a critical decision that must be grounded in objective data and a structured clinical assessment. Escalation is the counterbalance to de-escalation within stewardship, and should never be undertaken lightly, as it increases the risk of resistance. The fundamental question is the current regimen failing? Primary reasons to escalate therapy. There are several primary indications for escalating antibiotic therapy. The first is clinical deterioration or lack of improvement. If a patient remains febrile or shows signs of ongoing or worsening systemic inflammation, such as rapid heart rate, low blood pressure, or elevated white blood cell count, after 48 to 72 hours of appropriate empirical therapy, escalation may be necessary. Similarly, the development of new organ dysfunction, such as shock, respiratory failure, changes in mental status, or acute kidney injury attributable to infection, signals the need for reassessment. Local signs of failure, such as a wound that appears more inflamed or a pulmonary infiltrate that is expanding, also warrant escalation. The second indication is microbiological data suggesting inadequate coverage. If final culture and sensitivity results reveal that the identified pathogen is resistant to the current antibiotic regimen, a change is needed. For example, if a patient started on cefazolin for bloodstream infection with Staphylococcus aureus is later found to have methicillin-resistant Staphylococcus aureus, escalation to an agent like vancomycin is required. Isolation of an unexpected resistant organism, or the discovery of polymicrobial infections where the current regimen does not cover all organisms, also justifies escalation. The third reason is diagnostic uncertainty that evolves during treatment. New diagnoses that were not part of the original differential, such as discovering an intra-abdominal abscess in a patient initially treated for pneumonia, require coverage for additional types of bacteria. Finally, host factors can compromise treatment. Patients with severe immunosuppression, such as those with profound neutropenia, organ transplants, or other significant immune deficiencies, may need broader-spectrum agents if they do not respond rapidly to initial therapy. Given the dire consequences of untreated infection, the structured approach to escalation, the 5 domains before deciding to escalate, a systematic re-evaluation is crucial to prevent unnecessary broad-spectrum use. Clinicians should assess 5 domains. First, confirm the diagnosis. Is it correct, or could the symptoms be due to a non-infectious syndrome such as an autoimmune disorder or drug reaction? Second, evaluate the drug. Is the current medication reaching the site of infection at the appropriate dose? Consider pharmacokinetics and pharmacodynamics. Third, examine the dose. Is it optimized for this patient? Underdosing is a common reason for treatment failure. Fourth, assess the duration. Has there been sufficient time for the antibiotic to work, as most infections require 48 to 72 hours for a clinical response to emerge? Fifth, consider whether there is an undrained focus of infection, such as an abscess or necrotic tissue, which may require surgical intervention for source control. The stewardship balance. Smart use of antibiotics. Antibiotic stewardship and escalation are not opposing forces but rather complementary strategies. Good stewardship is dynamic, requiring clinicians to start with broad-spectrum empiric therapy in critically ill patients, reassess at 48 to 72 hours, de-escalate to a narrower agent when possible, and escalate promptly when there is clear evidence of clinical or microbiological failure. This thoughtful, data-driven approach ensures that patients who need powerful antibiotics receive them without delay, while minimizing the risk of resistance for the broader community. Is there a role for starting with the highest-tier antibiotic? This is a central and nuanced question in the stewardship conversation. The strategy under discussion, starting with a broad-spectrum, high-tier antibiotic, is often referred to as empiric therapy or front-loading. It has a critical, but specific, role. The short answer is yes. There is a definite, and often life-saving, role for starting with a high-tier antibiotic, but this decision must be guided by specific principles to avoid harm. It is a calculated risk-benefit analysis that weighs the dangers of undertreating a severe infection against the risks of promoting resistance. The rationale for hit hard, hit early. The primary goal of empiric therapy is to cover the most likely and most dangerous pathogens until specific culture data is available. Starting with an inadequate regimen in a severe infection increases the risk of clinical deterioration and death. Every hour of inappropriate antibiotic therapy in sepsis and septic shock is associated with a significant increase in mortality. Inadequate or subtherapeutic dosing can also inadvertently promote resistance by exposing bacteria to sublethal drug levels, allowing them to develop survival mechanisms. The framework for deciding when to start broad. The choice to begin with a high-tier antibiotic is never arbitrary. It is based on careful assessment of 3 key factors: patient factors, infection factors, and treatment factors. Patient factors include the severity of illness, such as sepsis or septic shock, which universally warrants broad-spectrum antibiotics within the first hour of recognition. Patients with compromised immune systems, such as those with neutropenia, advanced HIV/AIDS, organ transplants, or on high-dose steroids, cannot contain infections effectively, and any delay in effective therapy can be catastrophic. Other considerations include comorbidities like advanced liver or kidney disease, diabetes, or chronic lung disease, which increase the risk of poor outcomes from infection. Recent exposure to healthcare environments, such as hospitalization or residence in a nursing home, raises the risk of infection with multi-drug resistant organisms. Infection factors include the type and source of infection. Certain infections, such as hospital-acquired pneumonia, ventilator-associated pneumonia, healthcare-associated intra-abdominal infections, meningitis, and necrotizing fasciitis, are associated with a high burden of resistant organisms or a polymicrobial mix that requires broad coverage. Local epidemiology also plays a role. Stewardship programs track resistance patterns within institutions, and high rates of resistant organisms may necessitate empiric coverage for those pathogens. Treatment factors focus on the consequences of poor outcomes if initial therapy fails. In serious infections, the risk of missing the pathogen is death or severe disability, justifying initial broad-spectrum therapy. The critical counterbalance. The antibiotic reassessment. This is where stewardship principles come full circle. Starting with broad coverage is only part of the strategy. The commitment to reassess and de-escalate is what distinguishes responsible practice. At 48 to 72 hours, the clinical team must evaluate patient response, laboratory data, and culture results. If the patient is improving and the pathogen is identified, the regimen should be streamlined, narrowing the spectrum, switching to a targeted agent, and defining the duration of therapy to prevent unnecessarily long courses. Practical examples in clinical scenarios. Consider a nursing home resident presenting with sepsis. The recommended empiric regimen might include vancomycin combined with piperacillin tazobactam, covering both methicillin-resistant Staphylococcus aureus and resistant gram-negative bacteria. After 48 to 72 hours, the therapy would be narrowed or discontinued based on culture results and clinical response. For ventilator-associated pneumonia, clinicians might use cefepime or meropenem along with vancomycin or linezolid, given the high risk for Pseudomonas and methicillin-resistant Staphylococcus aureus. Once respiratory cultures are available, de-escalation should proceed aggressively. In neutropenic fever, broad-spectrum agents such as cefepime, meropenem, or piperacillin tazobactam are used because immunocompromised hosts cannot control infection effectively. Therapy is adjusted based on culture results and continued until neutropenia resolves if no specific source is found. For uncomplicated urinary tract infection in a healthy woman, narrow-spectrum antibiotics such as nitrofurantoin or trimethoprim sulfamethoxazole are preferred. These agents are highly effective, minimize collateral damage to gut flora, and prevent resistance. No escalation or de-escalation is needed if the patient responds appropriately. Conclusion. Balancing immediate needs with long-term stewardship. To summarize, starting with the highest or second-tier antibiotic is a cornerstone of modern infection management, reserved for situations where the risk of treating a severe infection outweighs the risks of broad-spectrum antibiotic use. The stewardship principle is best captured by the phrase, start smart, then get smarter. Begin with a broad, well-informed empiric choice based on patient, infection, and drug factors, and then refine and narrow that choice as soon as more information becomes available. This approach balances the urgent need to save lives with the long-term imperative to combat antimicrobial resistance. Thank you for joining this podcast discussion. Stay tuned for more conversations on optimizing antimicrobial therapy and advancing patient care. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.